For the sake of audience, we will be discussing for the next few minutes about the transcatheter aortic valve implantation, lovingly called TAVI, how it gives a new life to the patient. Myself, Dr. Tom Davis here from Temple Town of Udupi, Professor of Cardiology. So let us start from the basics. What is TAVI? TAVI is the transcatheter aortic valve implantation. It is also otherwise called TAVR, transcatheter aortic valve replacement. It is just that a name people call in US, they call it TAVI, and in Europe they call it TAVR. Both are actually the same. Fundamentally, it means that the aortic valve is replaced without an open heart surgery. Sure. This is a life-saving procedure for symptomatic severe aortic stenosis patients. Now you can see on the left-hand side the normal aortic valve. That means it is a gate that is between the left ventricle of the heart, that is a chamber that pumps blood into different parts of the body, and the aorta is on the top, which is it's a tube carrying the blood to the rest of the body. So aortic valve is essentially this gate between left ventricle and aorta. And you can see that on the left hand side it is opening normally during the pumping of the heart. However, when there is stenosis, you can see that this gate doesn't open fully, and that means a good volume of blood does not enter the aorta, so that the rest of the body do not get the blood supply that is required. So whenever there is aortic stenosis, there is reduced blood flow to the body and increased left ventricular pressures. How do we suspect that you are having this disease? The patient will have such symptoms of shortness of breath, extreme fatigue, and when they walk, they may feel giddy. And there will be, when you look at the patient, there will be other features of heart failure like leg swelling. So if you see an elderly gentleman with all these features, there is a good chance that this patient may be having aortic stenosis. The classical features of aortic stenosis would be angina, that means chest discomfort or a tightening feel in the middle of the heart of the chest that shows that is called angina. The patient can also have syncope, that means that when the patient exerts himself, he feels giddy. And they can also have dyspnea, which means that when the patient walks or climbs uphill, they will have shortness of breath. So when they have these symptoms of shortness of breath, that is a symptom of heart failure, then you should know that in these patients with narrowing of the aortic valve, otherwise called aortic stenosis, the life expectancy is less than 1 year. So you need to act smart and act swift. You know that the age-old therapy for this aortic valve stenosis has been surgery, which is called lovingly SAVR. That means surgical aortic valve replacement. You can see that it opens the chest wall through the sternum, that is the middle of the ribs, and then cuts it open, and then the surgeon cuts open the heart and then puts an artificial valve to make the heart function back again after removing the damaged valve. And in transcatheter aortic valve replacement or implantation, you can see that a small tube goes in with a balloon and a valve loaded on it, goes to the location of the aortic stenosis, and then it expands and pushes out the damaged valve to the wall of the aorta, and the new valve sits in that position of the original valve, functioning as a normal valve. And this is a bioprosthetic valve, which means that this valve is entirely made of biologic material, not a metallic thing as we do usually in a surgical aortic valve replacement. So how do we take this valve to that normal position of the aortic valve between the left ventricle and the aorta? We go through the veins of the through the arteries of the leg, and that is commonly the femoral artery. However, you can have access to the heart through any part of the body, like the legs, the shoulder, the chest, and neck even. Now, let us see how this treatment of severe aortic stenosis evolved over the years. In 1980s and 1990s, surgical aortic valve replacement, that is open heart surgery, was the only option. And there was a large number of cases who were inoperable, and surgery was deferred due to high risk for surgery. The patient would be very elderly, patient would be very frail, patient would have multiple problems like lung disease, which means general anesthesia is going to be risky for him. Patient would be having diabetes, which means that if you cut open the chest, then the recovery and the wound healing would be very much in trouble, and there would be increased chance of infection, which would be very miserable for these patients. So surgery was the only option still then. And for the first time in 1985, the first in man balloon aortic valvuloplasty, that means the narrowed valve was expanded by an appropriate size balloon. It is called the balloon aortic valvuloplasty. It was done for the first time in 1985 by Professor Dr. Alain Cribier, and he published it in the Lancet journal in 1986. But then there was no valve available to implant in that damaged valve position. So they started the animal studies to develop a valve in around about 2000. And in 2002, April 16th, for a 57-year gentleman with severe aortic stenosis, pulmonary edema, that means fluid in the lungs, cardiogenic shock, that means very low blood pressure, and resuscitated cardiac arrest, that means patient has already had a cardiac arrest, the heart had stopped, and they had to give cardiac massage to resuscitate it. And peripheral vascular disease with both occluded peripheral grafts, that means the femoral artery access was not possible to take the valve to the normal position to implant it using the balloon. In such a sick patient, which is definitely a surgery turned down because of the high risk of the surgery, the first in man transcatheter aortic valve implantation was done successfully and published in the Circulation Journal in 2002 by none other than the father of TAVI, Professor Dr. Alan Crebier. This was the first ever TAVI done in 2002, and you can see the anxiety, the excitement, and perhaps the fear in the face and the eyes of the doctors, the supporting team. And luckily for the patient, he did quite well and he survived. You can see him with the doctor in the right lower corner. This is a timeline of the evolution of TAVI, how it all evolved. In 2002, the first TAVI implantation was done by Professor Crebier, and then he had to that patient was a friend of the doctor, and so he had to do large scale studies to show that it is a feasible in human. And then it went on like that, and then the first transapical TAVR, that is through the chest wall directly over the heart, they made a hole and then put the valve inside. That was done in 2004. And then for a patient who already had a surgery valve, after many years, the valve degenerated and the patients again the valve became stenosed. So they had to redo another valve TAVI because he was again turned down for surgery after 10 to 15 years after the first surgery. So they turned down the surgery, so he had to be a candidate for TAVR. And this time, the first valve in valve TAVR was done by Eberhard Grube in 2007. And then again, there was published randomized trial for high risk patients in 2010, and they had an axis other than the legs or other than the apex. They used around the shoulder, the transaxillary axis, to implant this valve for the first time in 2009. And they did through the vein of the leg in 2014, and then 2013 onwards, the size of this valve and the device started to become smaller and smaller, and technologically we decided to advance further, and then we got more advanced technology, so more smaller size valves which could be crumbled to a smaller size so that passing it through the leg arteries became easy. Then they moved from very high risk and surgical turn down patients to intermediate risk patients in 2016, and there was in 2019 they published their randomized trial reports for low risk patients. So you can see that since the first balloon aortic valvotomy, 30 years have passed, and since the first in man aortic valve replacement, 20 years have passed. So it has been very much in use across Europe and US, and recently India also has caught up with it. This is just a review of literature which I had shown you once again. What is important is from 2007, the Partner 1 trial, when they used to compare or do this TAVI for high risk inoperable surgical turn down patients, they moved to intermediate risk patients where it is possible with TAVI in 2011. And FDA, the US FDA, which is the authority to control and regulate these things, they gave approval in high risk inoperable patients in 2011, and they gave approval for intermediate risk patients in 2016, and they approved even for low risk patients in 2019. So this is the most important trials. In 2010, the Partner 1 showed that the TAVI is beneficial for patients with aortic stenosis with prohibitive risk for surgical aortic valve replacement. And then in 2016, the Partner 2 trial came to show that in intermediate risk patients, TAVI is non-inferior to surgical aortic valve replacement. And in 2019, as I already explained, the Partner 3 showed that in low risk patients, TAVI is superior to surgical aortic valve replacement at preventing the death, stroke, rehospitalization at 1 year. So as of now, as of today in India, TAVI is a less invasive alternate to surgical aortic valve replacement. TAVI has revolutionized the management of severe symptomatic aortic stenosis, and it has become the standard of care for patients with prohibitive surgical risk. And it is the preferred treatment for many intermediate and high-risk elderly patients. 2011, FDA team approves TAVI. The first TAVI in India was done in an 80-year-old female. And in Manipal in 2020 New Year, we did the first successful TAVI in an 80-year-old male patient. This is me and my team who did the first TAVI in Jan 1st, 2020. We can see how happy we all are after that complex procedure. We all had a great time after that, and this is a group snap which we took on that day. So our TAVI team consists of cardiologists, cardiac surgeons, vascular surgeons, electrophysiologists, anesthesiologists, and of course the entire team of cath lab, including the technologist, the ICU staff, and the cath lab sisters as well. We have given new life to all patients by doing transcatheter aortic valve replacement at our center in Manipal. And it is very important that if you want to know how it feels like, it is like a patient who has been hanging a brick onto his neck for years together, and every year the weight of the brick goes up, and it comes to a level where they can no longer handle it. And one fine morning, when you remove that brick from the neck, that is akin to doing a TAVI. You can see that the next day morning, the patient sits up, the patient who could not sit properly in his own bed, he jumps up in bed, walks around, and then he feels that he has been given a new life once again to start with. The change is phenomenal on the next day of TAVI or after the TAVI is done. You need to see it to believe it. That is me on that picture with Professor Dr. Alan Kribia, who is the father of TAVI worldwide. So let us see a few case examples and know what is it that's happening here. This is a sample case we did. This is an 80-year-old female who presented with sudden onset of breathing difficulty, and the hemoglobin was low. The heart rate was 100, the blood pressure was 110, and the ECG showed evidence of left ventricular hypertrophy or thickened heart with some conduction abnormality. That is the echo image on the right hand side. You can see that there is severely calcified aortic valve and the mean gradient of more than 40 showing severe aortic stenosis. You can see that there is barely any opening of the aortic valve. There is left ventricular hypertrophy and the ejection fraction is 60%. So I am showing with where the aortic valve is there and it is heavily and densely calcified. Sure. The patient, we always have a discussion in the heart team consisting of myself and the vascular surgeon, the cardiac surgeon, the anesthesiologist, and of course, the electrophysiologist. So if the patient is a high risk for surgery, we talk to the relatives and the surgeon will tell that we may give preference to non-surgical TAVI because of the advanced age and comorbidities. So we need to stabilize the patient initially by giving diuretics, some injections, so that the lungs or the fluids in the lungs is removed. And this patient, even after initial injections, she continued to have breathing difficulty because we did not really correct the underlying problem of severe aortic stenosis. So we do an angiogram as a preparatory test and showed that there are no blocks in the heart, only the valve was severely calcified. So these kind of patients, the best treatment option would be the transcatheter aortic valve implantation or the TAVI. So before we do the procedure, we do a CT scan, and these are the images and the findings of the CT scan that we will get. You can see that the aortic valve perimeter, area, LVOT diameter, all these are assessed. And you see the height of the coronary arteries from the aortic valve. You see the sinus of Valsalva diameter, and you see the severity of calcification of the aortic valve. And this is the various views of the CT scan. You can see that heavily calcified aortic valve that is responsible for very poor opening. So how do we do it? You go from the femoral artery on the groin, and then you send a pigtail to the aortic valve, and then you do what is called an aortogram. The aortogram is just like a scout film we do to show that the aortic valve is not opening clearly and where the aortic valve is. Then we pass the python sheath. As the name indicates, it is a sheath that can expand considerably when the valve is passed inside it, just as the python can swallow a big goat much bigger than him. So this is passed across the iliac vessels, which are usually calcified, and then we need to cross the aortic valve using a catheter called the Amplatz catheter with a straight tip wire. You can see how the wire and the catheter is used to cross the aortic valve and push the catheter forward over the wire to slip into the left ventricle. That is the position that we want to keep our wire in, and then over this catheter we put a very stiff wire called the short loop safari wire to give stability to the wire, and then we push the artificial valve, which I am showing right now with the laser pointer. This artificial valve, which is crumbled, is positioned properly in relationship with the dot, and then we confirm the position of the valve. And once the valve position is confirmed, you can see in the laser we expand the valve with the balloon, and once the valve is fully expanded, we deflate the balloon so that the valve remains in position. The deflated balloon can be pulled back over the wire. And this is how the final result would like. The expanded valve will work or function as the new valve, otherwise called the neo-aortic valve. And the pigtail injection shows how well the valve is functioning with the valve, or the gate is functioning with minimal resistance to outflow of the most important chamber of the heart, the left ventricle. So the gradient or the obstruction across this gate or the aortic valve came down from a mean gradient of 50 or 40 millimeters of mercury to less than 10 millimeters of mercury. That suggests that it is a successful procedure. We confirm that the heart blood flow to the heart is also flowing normally through this. So you can see that how in the laser the very calcified valve in this location is replaced by an artificial valve, and how very well with each heartbeat this valve is opening so that the blood flows smoothly into the rest of the body. Yet another case example, this is a 71-year-old male who was high risk for open heart surgery because he had chronic obstructive lung disease, severely damaged lungs. So he presented to us with acute breathing difficulty, and same echogram showed the severely calcified aortic valve, as you can see in the laser pointer, and the aortic valve area that was calculated was zero point 0.3 centimeter square with left ventricular hypertrophy and an ejection fraction of 56%. So we discussed with the surgeon, and he felt that the patient was high risk for surgery because of this severely damaged lungs. So again, this patient becomes a candidate for transcatheter aortic valve replacement. As I had already explained, the patient undergoes a pre-procedure CT scan evaluation, and you can see that it is a bicuspid aortic valve with heavy aortic valve calcification. And these are the measurements, and with using these measurements, we select an appropriate size aortic valve to be positioned at the site of the diseased aortic valve. You can see, as usual, we do an aortogram. You advance the Python sheath, and then you cross the calcified aortic valve using the Amplatz catheter and the wire, and then we position the valve across the diseased native valve, and then you slowly expand it. And once it is expanded and the valve is totally deployed, the balloon is deflated and taken out. And the final result, as you can see, there is a new aortic valve functioning like a normal valve, and the old damaged valve is pushed to the side. This is the final result of the um, procedure, and you can see that after the TAVI, the gradient has come down to below 10. We usually discharge the patient on the third day of the procedure. This is me and my team with the patient and the relative. You can see how happy the patient is and how healthy he looks, and you can feel the smile on his face of going home in a much healthier way on day three after the procedure. Different centers have different protocols. Now there are many centers in US and Europe which discharge the patient either on the same day or on the next day. But in our center, we discharge the patient after day 3. Yet another patient who came to us with giddiness, and the reason for giddiness was severe aortic stenosis. And this patient also had block in the heart called coronary angiogram related left anterior descending artery block. And this also heart team was consulted, but the patient refused open heart surgery. So in addition to a transcatheter aortic valve replacement, we had to remove the block of the heart also by putting a stent. So as usual, we do a pre-procedural CT scan, and after that we proceed with the procedure. So the block in the heart was first removed by putting a stent there, and once confirmed that the stent is all fine, we use uh, proceed with the same TAVI procedure with minimum use of contrast, because this patient also had some kidney related problem, and there was kidney dysfunction leading to kidney failure, and we did not want the patient to have end up in dialysis. So we used minimum contrast, and we did the TAVI procedure for her. And as in the usual case, we did the case, and this is the final result. You can see how well the valve is sitting excellently in the position of the valve, and you can also see a shadow of the stent that we put, as shown in the laser pointer. The echo also shows the severely calcified aortic stenosis as shown now with the laser, and you can see that the laser has moved to the new valve where the valve is opening very freely without any obstruction to the flow. There was no obstruction to the flow, and the patient's condition uh, improved dramatically. He was discharged on day 4, and there was significant improvement in symptoms. This is me and my team with my cath lab sisters and my colleagues and my cath lab technology specialist who helped me with the case. And we take a snap after each case of the TAVI is over, and you can see the happiness on our faces. This is yet another patient, 74-year-old patient with chronic obstructive lung disease, who came to us with dyspnea and heart failure. The blood pressure was low, as you can see. The ECG showed these changes, and the valve is so calcified. You can see in the laser pointer, the valve is barely opening. It is so severe, and the left ventricle, the heart pumping is also quite weak, and that means this patient is high risk for surgery, and the only way out for this patient is by doing a TAVI. You can see that this much weak heart automatically makes any patient high risk for a surgical procedure. So the surgeon straight away denies these cases, and then we go ahead as a heart team and then proceed with TAVI. This is the CT scan pre-procedure evaluation. You can see, as usual, we proceeded with the aortogram, the Python sheath, crossing the aortic valve, which is heavily calcified, with the wire and the Amplatz catheter. It is difficult at times, but with patience you can do it, and then things becomes easy and safe. Then we position the valve properly, and you can see that the valve is positioned in the aortic valve location, and then we expand the balloon, and after expansion of the balloon, the aortic valve sits properly, and then once the aortic valve is fully expanded, the balloon is deflated and then removed. You can see that next day itself, once the obstruction to the outflow of the left ventricle is removed, then the heart itself will find more energy to pump. You can see that next day itself, in the pre-discharge echo, the ejection fraction of the heart, the contractility of the heart improved, and then at 1 month follow-up, it improved further. So you can see that in the visual image itself, the ejection fraction improved from 10% to 28% to 39% on 1 month follow-up without any gradient. The patient has significant improvement in benefit of symptoms, and you can see that the patient was discharged on day 3, and they are all healthy and active, and they feel 10 years young at least when they are ready to go home. This is yet another patient who was a transplant, post-transplant patient, a kidney transplant patient, who was on immunosuppression therapy, whose creatinine, new kidney also had some dysfunction. So the creatinine was around 2, came to us with breathing difficulty from across the border, and suddenly there was a recent worsening of breathing difficulty, and you can see that in the CT scan which we have taken, you can see the transplanted kidney that is usually seen in the right iliac fossa, that is the right side of the below the lower abdomen. And this echo showed severely calcified aortic valve with severe gradient across the aortic valve. So this patient had to undergo TAVI because surgery for him would be high risk, because he is already a kidney transplant patient, and his creatinine is already 2, and his he's on immunosuppressive therapy, and so any surgery there is a risk of immunomodulation or immunosuppression leading to wound infection. So this patient also was given a chance of TAVI, and we proceeded with TAVI, and you can see that after deployment of the valve was functioning finally, and the total contrast we used was only 10 ml, so that the patient new kidney, the transplanted kidney, was not damaged. You can see that on the pre-discharge echo, the aortic valve is functioning normally with no obstruction to the left ventricular outflow. This is the patient with us, smiling and sitting on chair on day 3. They are all happy. They feel that they have had a new life, and he talks and chats to us regularly, uh, just every day, happy as a new boy from school, uh, uh, enjoying the new lease of energy and life he has been given. This is once again our TAVI team with all of us, my colleagues, vascular surgeon, my sisters, my cat tech, all of us together celebrating the success of TAVI. Thank you very much.
Thank you, sir, for a wonderful presentation. So we'll open the question forum for the audience to ask few questions if they are interested. Or they can even put it in the chat box so that I can read it out to you.
So mainly the purpose of this talk has been more like an awareness of what there may be people in our family, elderly gentlemen who are suffering from many of these problems of breathing difficulty or giddiness while walking or chest discomfort while exerting themselves, and these patients could be potentially having aortic stenosis. And if you have confirmed aortic stenosis by echocardiogram, then we all should know that there is a potential option now with less risk, more safety than the surgical aortic valve replacement, especially in high risk patients and intermediate risk patients, the option of TAVI or transcatheter aortic valve implantation. If I could get across this information to these audience, I would be happy. Thank you.
Sir, thank you for your talk. I have a question. Can I ask?
Sure.
So, how does the learning curve for performing TAVI impact patient outcomes, do you think?
Yes. So we need to do these cases initially, a few cases with the proctors first, and once we have the confidence, and then the proctors develop confidence in us, then we can start doing by ourselves. In this region across the coastal Karnataka, I am the operator who is able, who the people are confident of doing without a proctor's help. And if we leave Manipal across this belt, then you can have in Bangalore, in Mumbai, across the border in Kerala, in Pariyaram, Calicut, there are operators who can do without proctors. But otherwise, if anybody else would want to do, then obviously the patient, once the patient is ready, the proctors and the valve will come together to help the cardiologist with the procedure.
Thank you, sir. So, can you throw some light on different types of valves that are available for TAVI?
Yeah.
The main
So
valves that are used.
the TAVI valves are all biologic valves, and these valves usually are of two types: the balloon expandable ones and the self-expanding ones. You can choose either of those, or you can master one and keep using. Mainly, it is based on the CT scan findings that the size of the valve is selected, and based on that, either a self-expanding valve or a balloon expandable one by various companies would be selected for implantation.
So, when you do the first TAVI on a patient, do you also plan for the second one?
When you are planning for first TAVI itself, it is, as I've already discussed, it is usually a high risk elderly gentleman or an intermediate risk people. So most of these people are actually above 65 years, and the one TAVI valve that you implant is supposed to last around 10 to 15 years. And that means the India per se, we have started after 2010, and across the last 5 to 10 years, it has been more common in India. So implanting a valve in valve is still not common in India as such, but then across Europe and US, it is quite rampant because they have been using it for a long time. So implanting a valve in valve, a TAVI valve in valve is there more regular. As of now in India, it is more like a TAVI in a previous surgical bioprosthetic valve, which was implanted maybe 5 or 10 years back. But at
So,
least once we have started using it, now, as I told, we are rampantly using it now for all the high risk cases. So if the patient is now 80 years, and then after 10 years they'll be 90 years, and if the valve is degenerated, then potentially we may have to use a lot of TAVI in TAVI in the future. Yes.
So the patient is around 50 to 60 years, let's assume, sir. It's a high risk patient still. So would you go for an open heart surgery or you go for a TAVI in this patient? Because the patient says now I can take open surgery because maybe in the future again I might need a second surgery where the valve can be put. How do you see that?
Yes. So very good question. So if the patient is only 55 years of age, and if the heart team decides that this guy is a low risk for surgery, then his first choice would be a surgery. And after surgery valve is again damaged and deformed, that is after maybe 15 years, that time he would be 70. And that time, if the surgeon heart team again feels that he is at high risk for surgery because of advanced age, frailty, or lung disease, or kidney disease, or whatever other organ disease, then we may consider as a heart team the potential chance of putting a TAVI in him.
Do you think, sir, anatomy of the heart plays a role in successful TAVI? For example, if it's a small aortic root, let's assume.
Yet another wonderful question. I fully agree with you. If the patient anatomy is not favorable for TAVI, then we should not proceed with TAVI, especially in patients who are intermediate risk and low risk. If the anatomy is not favorable, please go ahead with the surgical aortic valve replacement and not TAVI.
So any future trends in TAVI, sir, with respect to new devices, new clinical trials, which you are aware of?
So many devices are coming into the field, and in a way it is good for humanity, because as of now one TAVI valve will cost around 13 to 15 lakhs. So as more and more devices and technological advancement happens, you get better devices, and there will be more and more companies coming in. That will mean that there will be competition, and the cost of these TAVI valves may come down, and that will make it more and more affordable for even middle class people. And sometimes we hope that in the near future, like the US and European and Japanese government, Indian government would be able to afford TAVI under some scheme for those patients who are even below poverty line.
So can you throw some light on paravalvular leakages that usually happens with these kind of surgeries?
Yes. So a paravalvular leak in a TAVI valve is not tolerated. That is why immediately after implantation, we reassess the paravalvular leaks for these implanted valves within 1 minute. And if we feel that even mild paravalvular leak is there, we do not tolerate it. The patient will not tolerate it over 6 months or 1 year. We have to be very aggressive with it. So if the patient, after the first deployment of the valve, if there is a paravalvular leak, then we may add 1 cc to the balloon and then inflate it again, so that the valve is little more expanded and the chance of paravalvular leak comes down. It is very dicey, because at one side you need to balance it off with paravalvular leak, and on the other side you need to balance it off with the risk of annular rupture, which is very, very risky, and the patient may be, it may be fatal for the patient. So you need to do it delicately after proper assessment. However, we do not want any paravalvular leak once the procedure is done. So within 30 minutes of implanting the valve, we should make sure that there is no paravalvular leak at all.
Can you throw some light on asymptomatic aortic stenosis where you have performed TAVI, sir?
So as of now, we are performing TAVI for patients with symptomatic severe aortic stenosis. And there is a lot of studies going on in asymptomatic patients with severe aortic stenosis, how TAVI is going to perform. There has already been data that patients without symptoms, those with severe aortic stenosis, the surgical aortic valve replacement is correct. And I think it is just a matter of time before we prove that once again TAVI in asymptomatic severe AS or TAVI in symptomatic moderate AS, both categories, TAVI is going to be quite useful.
What about calcified valves, aortic stenosis? Can still TAVI be done, sir?
Calcified?
Aortic stenosis, can still TAVI be done in that cases?
Most of the times, the heavily calcified aorta, the surgeon will find it very difficult to open. He will have a lot of difficulty during surgery, and there is increased risk of complications in such calcified aorta, which we call as porcelain aorta. So these kind of patients, the best treatment option would be a TAVI.
Okay. So I think I asked quite a number of questions. Thank you very much, sir, for your kind explanation.
You have asked almost all the questions a veteran would ask.
Thank you, sir. So any questions from audience?
I don't think there is any question left for the audience to ask because you have covered almost everything.
Okay. So I think then we can wind up, sir. It's a great pleasure to have you in the forum. It's a good talk and we learned something new. As you said, the essence of the talk should be to reach, create an awareness. What's upcoming in the field of cardiology, where earlier when you ask somebody there was a heart attack or something, they'll say we had a bypass. The only term that was used long in the decades was bypass. Then there was subsequent knowledge about PCI procedures. Then now it's the era of TAVI, where the more simplified way of treating aortic stenosis. Thank you very much, sir.
Thank you very much. The pleasure was all mine, and good night from all of us here. Bye.
Thank you, sir. Thank you.